Welcome to the 18th webinar in the colorectal webinar series. Today we will discuss the endoscopic approach to superficial colorectal neoplasms. And for those who are new to this webinar series, we started almost 2 years ago, and with we, I mean Walter Brunner, good colleague from Austria, and Andreas Chamillet, and of course, I mean Maite of Medtronic, which we organized a complete series with. 2 years ago, we started this webinar series, and we started with basic laparoscopic colorectal procedures and techniques, and we progressed in this year to more complex procedures such as rectal cancer surgery, APR, and TME. And due to the success of the series, we decided that this year we made a season 2. And in this year, we had modules on specific pathologies such as IBD surgery, Crohn, endometriosis, and the last module was on the ERAS protocol and fast-track surgery. All these webinars were recorded and will be part of an online training module, which is published on web search in the near future. So if you missed out on some of the modules, please log on in web search, and in the coming weeks, hopefully it will go live there. So today, like I said, we're going to talk about the endoscopic approach to colorectal neoplasms. And the faculty is, like I said, Walter Brunner from the Kantonsspital, and Walter invited a good colleague, Remos Frey, who's also from the same hospital, and Andreas Chamillet also invited a colleague, Alexander Shiai-Habi, and he will give a presentation as well. So we always start with the rules of the webinar, and please take the time to read them carefully. For us, it's really important that you ask questions, that it is an interactive webinar. So please, in the Q&A section, give your questions. We will collect them. We won't answer them there, but we will collect them and ask them to the experts at the end of the webinar. We always start with some questions in the beginning as well. So Maite, if you can start the questionnaires, the poll. So we always like to know where the participants are coming from. So please take the time to fill this in. Are you from Western Europe, Eastern Europe, Middle East, Africa, or somewhere else? So the majority is from Europe this time. Thank you. So the next question. This is the first time that we have a gastroenterologist also, I think, available. So please answer if you're a surgeon or a gastroenterologist. So the majority is surgeon, so that's good. So we can teach the surgeons a lot about a subject of colleagues in a different specialization. So the last question concerning your experience. So are you a resident? Are you just finished in a 0 to 5 years experience? Are you more experienced, or are you really experienced with more than 10 years of surgical experience? So we have a lot of experienced surgeons. That's good. So thank you very much for filling in these questions. I'll now give the words to Andreas so he can introduce his colleague. Andreas, the floor is yours.
Thank you, Colin. Welcome from Austria. It's a great pleasure to invite now Alexander Shiai-Habi. He is one of the leading endoscopists in Austria for interventional endoscopy, and the topic we are discussing today, he's doing it every day and all day, all night. Please, Alexander, let us know from your experience how to deal with these superficial lesions.
Yeah, thank you very much, Andreas. Thank you very much, Walter and Colin, for the invitation and the opportunity to do this talk. As a gastroenterologist, I just saw that I'm one of the minority here. Assessment of colorectal lesions will be my talk, and Remos afterwards is going to tell you how we attack these lesions. So to start with, and to get a little feeling how the experiences of the audience, I also would like to start with 3 poll questions. So may I ask Maite to show the first question. Do you know Paris, NICE, or chained classification for colorectal polyps? So yes, no, you heard about it, but you don't know exactly what it is. Or do you not perform endoscopy by yourself? Okay, so we will try to do this quite fast. So this is quite, half of you, yes, no, okay, thank you. So the second question, please. Do you use these classifications? So always, sometimes, never, or you don't do endoscopy? Okay, so sometimes, always, never, okay. And now the last question, please. How do you decide endoscopically whether a colorectal lesion has to undergo surgery? So you take biopsies if you're not sure and wait what the pathologist is telling you. You just inject under the lesion and see if it lifts. You decide if you see signs of deep submucosal invasion, or you do not do endoscopy by yourself. Okay, more and more in the questions are not doing endoscopy anymore, I see. But also this is a very, very heterogeneous thing we see here. Take biopsies, inject and see if it lifts, or you try to understand what you see. Okay, so assessment of colorectal lesions. I will want to start with one case report. A 50-year-old male was referred for rebiopsies. He was diagnosed as T3 rectal cancer in the MRI, and he was discussed in the multidisciplinary tumor conference, and radiotherapy, as it was a T3 cancer, was planned, and afterwards surgery. But this patient already had underwent 3 endoscopies, and several biopsies were taken, and the cancer never was proven because histologically all of them showed adenoma with low-grade dysplasia. So of course the oncologists and the radiotherapists, they said they have to have proof of the cancer first before they do that invasive therapy. So I show you the picture of this lesion. This is a patient who was in several hospitals, several doctors for many weeks now. He thought he has a T3 cancer. Also the MRI clearly did an overstaging. And when we look at this lesion and we assess this lesion, we decided a little bit different. John Kirkling, he's a surgeon by himself, and I like this sentence: surgery is always second best. So if you can do anything else, it's better. So what we did in this situation, there was no sign of cancer, so we did an unblocked resection by ESD, and it was just the adenoma with low grade and high grade dysplasia. So this patient did not undergo a deep rectal resection, which of course would have quite morbidity. So what are the aims of endoscopic resection? We want to remove precursor lesions. We want to prevent malignant tumors, so to reduce the surgical morbidity and mortality. And we want to improve life quality, especially to preserve organs. It's a difference if there's a lesion on the right-sided colon or in the lower rectum, because I don't have to tell anybody of you, the morbidity and also in some cases mortality of the rectal resection is relevant, and the life quality might be bad afterwards. So what are the requirements for a good endoscopic resection? At first, of course, we have to detect the lesions. So things like bowel preparation, advanced imaging, good endoscopic instruments are crucial for this. We have to be able to predict the histology due to the pattern of the lesion. And then we have to choose adequate resection techniques. We have to decide whether a lesion can be resected in piecemeal or if we have to do en bloc resection. We want to have as lowest recurrence rates as possible. So we also have to understand the limits of resectability. we have to understand what is oncologically does not make sense to do that. We always have to be aware of our personal skills. We should not start the endoscopic resection of a lesion where we think we are not going to finish it. In such cases, it's better to refer the patient to another center who is more experienced with advanced lesions, because big problems we have is to resect lesions that already were half resected or twice to resected. And of course, we have to be able to manage complications such as bleedings or perforations during procedures. So the plan we always do is when we see a lesion, we try to predict histology first, and then in our brain, we make a plan. If we have a lesion that is harmless, that is, for example, a hyperplastic polyp in the rectum, we just leave it, we don't have to do anything. If we see advanced neoplasia, then we take biopsies and we do a marking. And if the lesion looks adequate for endoscopic resection, we don't have to do anything. We don't take biopsies, because a polyp in the colorectum has to be resected anyway. And it's better to have a histology from the whole specimen than taking lots of biopsies, which might make the resection difficult. But if we choose for endoscopic resection, then we have to choose the adequate technique, which is dependent on the morphology of the polyp. So this is something we have to know, or we all know. This is the wall of a gastrointestinal wall, and we have the lymph nodes. And as long as we have just early cancer, there's no risk of involvement of the lymph nodes. But if the cancer has deep submucosal invasion, then the risk of spreading into the lymph node gets higher, and these patients are not adequate for endoscopic resection anymore. They have to undergo surgical resection with lymphadenectomy. For the different criteria, we have to be aware, and that is something we have to get from our pathologists. We have to distinguish between flat lesions or stalked lesions. For the flat lesions, in case of cancer, we have to get in the report the so-called Kikuchi levels, which tells us whether a lesion is invading just the upper third of the submucosal layer, which would be SM1, the middle third, which would be SM2, or the lower third, which would be SM3. For the stalked lesions, we have to get the so-called Haggard levels, which is dependent whether the cancer is just invading into the submucosal, but not only into the head, which is level 1. If it goes down the way until the neck of the polyp, it's level 2. If it goes into the stalk, but not beyond, it's Haggard level 3. If it goes beyond the stalk of the polyp, it's Haggard level 4. And the criteria for curative endoscopic resections are dependent on all these levels. So for flat and sessile lesions, we have to have criteria for curative endoscopic resections, which is at first degrading, which is grading 1 or grading 2. There has to be no lymph vessel invasion, and the submucosal invasion is limited up to SM1 or SM2. Of course, if you have endoscopic resection, you will not have the whole submucosa. So it's difficult for the pathologist to do the thirds and to tell you if it's SM1, SM2, or SM3. So we want to have the absolute measurement of the submucosal invasion depth, and the limit for that is at the moment 1,000 micrometers until it still might be resected as curative manner. And of course, we have to have, in case of cancer, a R0 resection. And this is the crucial point. If you want to have a pathological report that tells you it's R0, then you have to send the pathologist one specimen. So that's the reason why we have to go for en-bloc resection. In the stalk polyp, actually, it's completely the same, but you have to be aware that Haggard level 1, 2, 3 is curative, because, for example, if you have a 2 centimeter long long stalk in a polyp. And even if it invades 1 centimeter into the stalk, it's still a Haggard level 3, and still the endoscopy would be enough for this patient. So about the different resection techniques, you will have more, you will hear everything afterwards. Just these 3 things we use. We use polypectomy for stalk polyps. We use EMR just to remove the mucosa. And if we want to go for en bloc resection, we are limited to the size. If we have suspicious lesions where we want to go for en bloc resection, and we also want to take the submucosa, we are doing the endoscopic submucosal dissection. This is the algorithm of the ESG, of the European Society for Gastrointestinal Endoscopy. That is, I think, a very good algorithm how you deal with polyps due to the size and due to the growth type of the lesion. So if we have a superficial colorectal neoplasia, we first decide whether it's sessile or flat or it's pedunculated. The pedunculated polyps, of course, they can be resected by polypectomy. If they are sessile or flat, it gets a little bit more difficult. All the polyps up to 10 millimeters, so the small diminuate smaller than 5 millimeters, or the 6 to 9 millimeters, today are resected by cold snare polypectomy. We do not use biopsy forceps to remove polyps. That's one of my messages. And the lesions that are sessile or flat, that are larger than 10 millimeters, have to undergo advanced endoscopic imaging. And that's the central part of my talk. What is advanced endoscopic imaging? To identify the presence of submucosal invasion. So we have to be able to know the signs of submucosal invasion, because after this we decide how we remove larger polyps. If it's a non-invasive lesion, then we go for polypectomy or EMR. And if it's larger, we also can do piecemeal EMR. If it's non-invasive, piecemeal EMR is still okay. But if it's suspected for a submucosal invasion, we have to undergo en bloc resection. So if you're not able to do ESD, it's better to do a tattoo and then refer the patient to a center where they can do en bloc EMR or ESD. And if there are signs of deep submucosal invasion, we just do colonic tattooing. We take biopsies of the lesion and refer for surgical resection. Now, what is advanced imaging? How can we decide this? This is quite old. I'm sure you heard about the Kudo classification, which is very complicated classification from Japan, which mainly is done by zoom endoscopy with chroma endoscopy and so on. With that classification, the Japanese are able to precisely tell you the histology. But we have to be honest, in the Western part, this is not used because it's too complicated. So this is something which in the routine, I think, is not used too often. And I will show you how you easily can do that. So first thing is how you describe colorectal lesions. You have to describe the size of the lesion, because as I showed you in the algorithm, it's crucial to use the correct resection technique. We have to describe the growth form. Is it pedunculated or is it sessile? And then we have to look at the surface pattern, at the vascular pattern, to understand the histology. And of course, we have to exactly report the localization of the lesion. So to start with, the growth form, we describe it in the Paris classification. So we have the type 1 lesions, which are usually the polyps, which 1P is pedunculated, so the polyp with a large stalk, and then the polyp is a 1P lesion, which is just removed by polypectomy. The sessile lesions are the 1S lesions. And then there's the group of the class 2 lesions in the Paris classifications, which are all the flat ones. And it's also easy. 2A means flat elevated, 2B means flat, and 2C means flat depressed. And then we have the type 3 lesions, which are excavated, deep depressed lesions, which are usually advanced cancers. Another form we have to describe in the colorectum are the so-called lateral spreading tumors as soon as they get larger than 1 centimeter. And we distinguish between two large forms, the so-called non-granular type and the granular types. The non-granular types are those lesions that are completely flat, and there are also some pseudo-depressed lesions. And then we have these granular type lesions, which you all know, those are those really large lesions that might involve the whole circumference of the colon. We have homogeneous mixed type lesions, and we have to also describe this. And why do we have to do that? Because just by the growth form of a lesion, we know that every growth form has another risk of advanced histology. And from that, we can even just from the growth form decide whether we have to do en bloc resection or we can do piecemeal resection. So for example, if you have a LSD, granular homogeneous type, these lesions has a really low risk of advanced histology. So this lesion can undergo piecemeal EMI. You don't have to do the risk for ESD in such a lesion. But if you have especially the LST's non-granular types, the risk of advanced histology is quite high, so we have to go for en bloc resection. The next thing we have to look at is the so-called surface and vascular pattern. What we mainly use today is the so-called JNET classification, also from Japan. JNET classification is the Japanese NBI expert team. NBI is the chroma endoscopy from Olympus, but all the other endoscopy companies also have their chroma endoscopy, like FICE or whatever. It doesn't matter. What you see is mainly the same thing. This virtual chroma endoscopy helps you to see the vessels much better. And now we have 4 different types. We have the type 1, JNET type 1 means you don't see any vessels. It's completely whitish, no of this gray or brown vessels seen in these lesions. So a type 1 JNET lesion is either a hyperplastic polyp or a sessile serrated lesion. These lesions might undergo, if it's hyperplastic, if it's in the lower rectum, you just can leave it. If it's on the right-sided colon, it usually is a sessile serrated lesion, so you have to resect it. But then this big class of this type 2 lesions, if it's 2A, so if this the vessel pattern is completely regular and you see the diameter of the vessel is the same, it's actually a very nice picture, looks like it rained a little bit, but everything looks regular. Then it's a JNET 2A lesion, which usually will be a low-grade adenoma. But if this gets more irregular, but you still see the vessels, but their caliber is changing, they're getting thicker, they're just breaking through, this means it's a type 2B lesion. So this is an advanced histology and either high-grade dysplasia or early cancer. So these lesions, the 2B lesions, have to be resected en bloc. On the other side, if you have great amorphous areas where you don't see any vessels anymore, then it's a type 3 lesion, which is a sign for deep submucosal invasive cancer. So this is not adequate anymore for endoscopic resection. Yeah, so here's some examples of a typical JNET 1 lesion. This is a hyperplastic polyp. Here you see a large sessile polyp, but completely regular vessels in this lesion. So this is a JNET 2A lesion. In this case, you have a flat lesion, and if you look to the center, you see these vessels are getting a little bit thicker. It's a little bit more irregular. So this is a type 2B lesion. So this has to go en bloc resection. With this thing, I want to show you the important not, if you see a polyp, it's not the first thing you do to get the needle and to inject and see if it lifts. You first look at it and do the assessment to know what you're aiming at. And if you see something like this, with this chained 3 lesion, this is a cancer. So you don't have to take the time to try to resect this. So you take biopsies, you do a tattooing, and you send them to the surgeon. So at the end, I just want to show you some pictures to see how we try to aim these lesions. This is a polyp in the colon. So first we see it in the white light endoscopy, and the first thing we do before we do anything else is we change to chroma endoscopy, look at it at NBI, and then go close. And if you look at this picture, you clearly can see the borders of the lesion. You see surrounding chained 2A, so this is an adenoma, but in the center you see this border, it's getting different. So this is completely different to the side of the polyp. Even if you would take a biopsy from here, you will get an adenoma. But if you look at this, this is chained 2B. So I stage this lesion as a 1S 2A lesion. This is something you can discuss it if it's already sessile. That doesn't matter, but it's chained 2B. So we go for en bloc resection in this case. And what you see, it's an adenoma. And in this adenoma, there's already a very small 4 millimeter adenocarcinoma, but it was resected en bloc. So this is a curative resection. Another example of a completely flat lesion, but you see in the white light, it's reddish. This is a very dangerous lesion because it's easily overseen. So you need perfect preparation of the colon. The first thing we do, we change to NBI and we see, okay, this looks regular, but around here, it looks a little bit different. The vessel's getting thicker. So we also can do additional chroma endoscopy by spraying indigo carmine on the lesion. And we see, okay, this is not even taking the color. So this is staying red. So this is very suspicious. So we have to resect this lesion en bloc. And as you already see, as it's a flat lesion, EMR would be very difficult. So this is a good lesion for ESD. So I staged this as LSD non-granular type lesion 2B. And we also resected this en bloc. And this was also an adenoma. And in this adenoma, there was a 1.5 millimeter adenocarcinoma inside, but also curative resected. And 2 last slides. This lesion I showed you before, it's a LST involving nearly half of the circumference. And first we have to go close, we have to go for NBI and watch precisely the surface pattern. And we see this is a 2B lesion. So we also go for ESD, and this was resected en bloc and showed to be high-grade adenoma with high-grade dysplasia. Of course, this lesion also could be resected piecemeal, but the advantage of ESD in this situation is that we have 0 risk of recurrence of this lesion, which would then be managed probably more difficult. So the last point, actually, I think the smallest of the lesions I showed you, little polyp, maybe 1 centimeter. So I don't know, just inject and resect it. Don't do that. Go close. You look at it at NBI, and you see this amorphous area on the lesion. So this clearly is a deep submucosal cancer. So we don't have to do anything else than taking biopsies and tattoo it, send them to surgery. And this showed to be a T2 cancer with also positive lymph nodes. So I'm already at the end, and my take-home messages would be that precise endoscopic assessment of superficial neoplasms is the first step in every endoscopic resection. Biopsies should be avoided in resectable lesions. So we don't like flat lesions that have been biopsied 10 times and then sent for resection. So it has to be removed anyway. So leave it in, don't take biopsies if it's not advanced. The knowledge of morphology, surface, and vascular pattern is crucial to differentiate between low and high-risk lesions And Remus is going to show you afterwards how we deal with high-risk lesions to have the best outcome for our patient. Thank you very much.
Thank you, Alexander, for this really excellent, impressive talk and these wonderful pictures. I'm in a lucky position that we work together and we have a really good service from gastroenterologists for the surgeons. So, Alexander, I won't ask you some questions now. Please stay tuned. We will discuss this after the lecture from Remus, and all the people at home, please feel free to send us your questions in the Q&A question section, and then we can answer all your questions after the second lecture. Now I will give the word to Walter Brunner to introduce our next speaker. Walter, please.
Yeah, also welcome from my side, and it's really a pleasure to have a lot of surgeons here. We had the questions, and most of you are the surgeons and some gastroenterologists, because it's very necessary that we see all those neoplasms as a team approach. And it's a pleasure for me to introduce Remus Frey. He's one of our leading gastroenterologists who really brought the advanced endoscopic techniques in our hospital, and it's also a pleasure to work with him. As it was already said that Kirklin in 1914, he was born and said surgery is the second best. I want to point out that he nearly died when TME and modern surgical techniques was introduced. So maybe he was not right. On the other hand, we know the morbidity and also the function after big resections. Obvious, sometimes it's better to have the small resections if this is possible, and Remus will show us a lot. And in the end, we will discuss the gastroenterologists and the surgeons together. Remus, please.
Perfect. Thank you very much. Thank you very much, Walter, for this for the invitation and for your kind introduction here. It's a great honor for me to speak about a topic that is that has become like a topic on its own in interventional endoscopy, and this is the advanced endoscopic resection techniques. And my talk will be about these techniques, about the resection techniques and the spectrum. What can we offer? Alexander already told you that for each lesion, we have a specific endoscopic resection technique that is tailored for this lesion. So just to remember this, every metastatic colorectal tumor grows on the basis of a small benign lesion. And it's the goal to recognize these lesions, to treat them before they are malignant. So this is the primary goal, but we will see that also in very early forms of malignant tumors, we can be endoscopically curative. So we've already heard some of these aspects like cold snare polypectomy, endoscopic mucosal resection, ESD, endoscopic submucosal resection, and EFTR. We didn't hear that. Endoscopic full thickness resection is a quite novel technique that offers a new aspect of resecting a total wall, giving us lesions that couldn't be resected before for endoscopic resections. The more advanced the lesion gets, the deeper the resection has to be. And we've heard that the curative resection is a T1B SM1, which is below 1000. These are still the guidelines that we use, that we hold on. It has to be R0, no lymphovascular invasion. It has to be a G2, and there is no tumor budding in the resected specimen. And then the risk of lymph node metastasis is very low, below 3% or even less. So what does that mean? We have to give the pathologist the specimen that gives him enough submucosal tissue to make the proper diagnosis. So if we go with a very early lesion, a benign lesion, and we take cold snare polypectomy, we just resect up to the muscularis mucosa. If we go for EMR, I will come on that, we probably go in the upper part of the submucosa. If we go for the ESD or ESR, I will come on that, we go in the very deep mucosa and probably until the muscularis propria layer. And in the full thickness resection, as the name says, we take the whole wall. of the colonic wall, knowing that we just need actually the total submucosa to be curative in an endoscopic way. But we will see why full thickness resection can make sense in a technical way, not in an oncological way. But sometimes full thickness resection can actually make sense. So I will guide you through these techniques, and this is probably the most easy technique, but it's evolving. And since these small polyps, they make up about 80% of the polyps that we found, cold snare polypectomy is very easy done. And this is how it works. So cold snare means the snare cuts simply in a mechanical way. So there is no application of current, but just through mechanical, in a mechanical way, it cuts the lesion. You see here, this lesion, it mustn't be injected. This is actually after injection, we call it then an EMR. So usually you just put the snare on the lesion and then you pull it through, or your assistant pulls it through, and it gives you a very clear cutted resection site at the level of the muscularis mucosa, more or less. But for small lesions, you see the results here. This is a very safe and a very effective technique with very high R0 resection rates, very low bleeding rates. And as Alexander said before, no forceps polypectomies should really be avoided, because the R0 resection, I mean, we can't talk of a resection. It's a biopsy that we take. So if we talk about resection, we start with cold snare polypectomy. This is probably for gastroenterologists, the most important technique. But we advance, if the lesion gets bigger, we resect it with endoscopic mucosal resection. Of course, we do the advanced imaging, as we heard before, but a lesion like this is a sessile, a Paris 1S lesion, more or less, a little less than 2 centimeters. We inject it, we make a submucosal injection. Then we have this typical lifting sign, which is very important to resect safely the mucosa and the submucosal tissue in the upper part. And then we pack it with a snare and resect it then in here one piece. This is an en bloc EMR up to 20 millimeters. These lesions can be resected en bloc in EMR, in classical EMR technique. We heard about this lesion before. This is a lateral spreading tumor, as Kudo described them first in '93. This is such a granular type, and it's a granular homogeneous type, as Alexander taught us in his lesson before. We see here the chromo endoscopy showing very precise the surface of the lesion, which is like a Rice Krispies lesion. And these lesions, as we heard before, they are almost never malignant. So they can be resected in a piecemeal manner. They differ. Also granulars that have an dominant nodule, they have an invasion rate of more than 10%. So these lesions, we shouldn't, this one with the dominant nodule, we shouldn't resect in piecemeal, but we should go for en bloc. And especially for these non-granular types, where the risk of malignancy is very high, there is simply no other chance than to resect them in an en bloc technique. So this is how a piecemeal EMR, or a wide field as it is called also, a wide field EMR works. So we sequentially inject a fluid in the submucosal layer. So we use indigo carmine in addition, so that it gets blue and it delineates very nicely the normal tissue from the polyp tissue. And what you see here is that the snare is placed, and then we go for piecemeal, which means we resect piece by piece and try to be complete so that we don't leave any bridges of polyp tissue. always when we resect in this technique, we have to do an early control, usually 3 to 6 months after the primary resection, just to make sure that we have no recurrent or residual adenoma. This is such a lateral spreading, granular homogeneous in the deep rectum. This is also a piecemeal resection because it's a benign lesion, as we know. And they are very effective, these resections. We have a low rate of complications, high rate of complete resections, and also if they go down to the dentate line, so the resection can be made totally, so that the rates of recurrence is not too high. If we respect like the margins, and if we respect that we don't leave any bridges during resection. This is the problem in EMR or in wide field EMR. This is recurrence. This is probably the main problem of piecemeal resections. We look very closely after having resected the lesion. We look very closely with high definition, even NBI, or with magnification on the resection margins, exactly to find these rests of polyp and to resect them to get a clear and insano resection. We don't like these recurrences. Usually they are flat, usually they are scarred, and they are sometimes hard to resect. So we use ESD techniques to resect them. But since we find them everywhere, these recurrences, and ESD is mainly or done in the rectum and in the stomach also, but not in the rest of the colon. So we have to be very careful in resecting these recurrences, these flat and scarred recurrences. This is one of the largest series I know from Moss and from Michael Burke from Australia, showing 1,000 patients who had a wide field EMR, and almost 800 coming for the first control after 4 months. And there was a recurrence rate from 16% in these patients. This is low for an EMR. We find recurrence rates that are higher, up to 20 or 25%. But what you see in this series is that even if a recurrence comes in piecemeal EMR, if the recurrence comes, you can resect it in a high percentage. You can resect it endoscopically. And if the second recurrence comes, you still are very effective in endoscopic resection. So if you take all the lesions, and you see that 93% of lesions are definitely endoscopically resectable, which is a rate that is very high. This is something newer, so you can also do piecemeal resections, not only in the hot snare technique or the hot EMR technique, but also in the cold snare technique. So the lesion is resected in an only mechanical way, but in a piecemeal manner. And this is the data that is available now, that the recurrence rate is not too high, but we find a difference in recurrence rates following histology. So if we take adenomas, we have a quite high recurrence rate of 11%. If we take the serrated lesions, they have a very low recurrence rate, so that we can say in serrated lesions, which are often larger lesions, the cold snare piecemeal EMR technique is a safe and effective therapy with low recurrences. And you see on the bottom, there is no perforation, so it's a very safe technique also. We do bleeding prophylaxis. This is something we talked about, or Alexander talked about the complications, that we have to be sure that we can fix them ourselves. So bleeding is, of course, one. We have learned that when we have large right-sided lesions, larger than 20 millimeters, that a complete clipping of the lesion leads to a reduction of the post-polypectomy bleeding rate on a factor 3. This is only correct for right-sided lesions, for large lesions, and if the lesion can be completely clipped. So it's not enough just to put one clip. If we see a vessel or something, you put one clip. This is not enough. So we should, if we do that in an older patient, a patient who has anti-abrogation or anticoagulation or who needs one, we have to do the bleeding prophylaxis. We have to really close the whole resection site, and this makes sense on the right colonic side. That's when we do that. So when we have increased risk of malignancy, and we heard the criteria, it's the Paris 2C, the LST non-granular, the flat ones, the LSG with dominant nodule. We heard that malignancy rate of about 10%, or if we have a JNET 2B, probably up to 3, I'm not sure, it's probably a 2B, then with this irregular vessel pattern, the irregular distribution and an irregular surface pattern, these lesions have to be resected and blocked to get a proper histology. This is again the criteria for endoscopic resection, and we have to get for the pathologist an one-piece resection so that he can definitely say that it's a T1B. So we have to give him enough submucosal tissue, and R0, so we have to give him a single resection piece. So what are these en bloc resection techniques? I go through that. So if the lesion is not too big, up to 20 millimeters probably, the data are not too bad for that, endoscopic mucosal resection can be en bloc, as these pictures show. So we make a submucosal injection, and then we resect it with a snare, so that the en bloc resection is being done by classical EMR. Then we have the submucosal resection or dissection technique. The ESR is probably something a little bit newer. It combines, it's a hybrid ESD technique, so it combines ESD, so we do a circular incision. Then we have a special snare. This works only for smaller lesions where the snare can be put in the rim, in this incision rim, and then the resection can be done with a snare. Very deep submucosal resection actually on the muscle layer. And then there is classical ESD, where we make the proper dissection of the whole submucosa, which is a little bit more time consuming and takes a little bit more training. And then we have the full thickness resection, an endoscopic technique that takes away the whole colonic wall. I will come on that. So this is such a lesion, an LST granular mixed with a dominant nodule, and we are not very happy. This is in the cecum, and as I told you before, ESD in the cecum, not many people do that. In Asian countries they are doing this. In Europe probably it's not that common to do ESD in the cecum, but still we can adapt a resection strategy, knowing that the malignant part of this lesion, of this granular mixed type, is below the dominant nodule. And the resection strategy can be that we resect the benign regions of the lesion in a piecemeal way, and then we take the dominant nodule en bloc with enough submucosal tissue. So we combine actually the advantages of the en bloc technique doing a piecemeal with this specific resection strategy. This is how it looks like. So we take the benign parts of the lesion in a piecemeal technique, and then until we have this dominant nodule, and then we take the dominant nodule en bloc to get the complete resection. This was a high-grade dysplasia, not an invasive cancer, but the high-grade dysplasia in this lesion. Of course, we would do ESD if this lesion would be in the rectum. This is such a lesion in the rectum, and it's also an LSTG, a granular type, but also with dominant nodules. So we go for an ESD, or here in this special case in an ESR, which is a circular incision with a special knife and then with a partially insulated snare, you can do the resection in one piece. This works only if this snare can be placed correctly and if there is no three-dimensionality of the lesion. If it's quite flat in the lower rectum, it works quite good. In the ultra-deep rectum, it's impossible. So if you have to accept the three-dimensionality of the rectum, it does not work then. But in such a lesion, it is a very effective and a very time-sparing intervention, actually. You see here then the resection specimen, which is an en bloc resection specimen with the dominant nodules. And here you see the resection site at the proper muscle layer. So a very effective resection technique. If we have a perforation, we can usually fix it ourselves. So we have different kinds of clips. This is an over the scope clip to close this perforation in the rectum. So usually in the rectum, we have not a problem because we are in the retroperitoneum. So if we have a small perforation, it's not that bad, and usually we can fix it ourselves. Coming to proper ESD, especially when we have larger lesions and if they have the criteria for submucosal invasion, we go for ESD. ESD means we make a preparation of the submucosa on the proper muscle layer. This is a very deep lesion, an LST, granular mixed with big nodules in the ultra deep rectum, and coming from here, from the sphincter muscle, preparing the whole submucosa on the muscle. And you see then the definite result in the in the ultra deep rectum. That's the result after ESD, going down to the anal channel and the resected specimen on the right. So if it's in the rectum, we definitely go for ESD in these lesions. This is a series from Andreas Probst and Helmut Messmann, and it shows quite nicely how ESD in Europe probably works. So they collected 300 ESD procedures, and it's interesting, they had the indication for an ESD, so a rectal lesion with signs of submucosal invasion. 83% were benign lesions. 17% were submucosal invasive cancer, so-called SMICs, and 83% of them were non-curative. Why? Not because they were not R0, because the depth of invasion was out of the limit of 1,000 microns. So the primary aspect of the lesion was it is endoscopically resectable, but finally, a large part, 80% of them were non-curative because a deeper infiltration than 1,000 microns. The R0 resection rates, they raised during the study period, and you can see that ESD takes a lot of time to learn and to be safe in. So at the beginning, they had a resection rate from R0 resection from 50% or a little bit more. And during the study, the R0 resection rate grew up to 85%. You see the recurrence, the bleeding rate, the perforation rate, you will find them higher than this. This is a very low perforation rate for ESD, but these are the data that we have. So there is a learning curve, and but still at the end, probably we will find us in these regions of R0 resections. So I come to the most invasive endoscopic resection technique, and this is endoscopic full thickness resection. This works with an over the scope tool. It's a cap actually that is mounted on the endoscope. This cap carries a clip and a preloaded snare, and the mechanism is as follows. So you first recognize the lesion and you make a marking there to make sure that you find it. Then you mount the tool, the EFTR tool, and then you go to the lesion. Then you grab it with this grasper. This is like a big biopsy forceps. You grab it and then you pull it into the cap. Then the clip is deployed, and as the clip is deployed, then the preloaded snare is closed and the lesion is resected. This technique is pretty safe, but has a limitation, like lesions that are smaller than 2 centimeters can be resected due to the size of the cap. Indications are non-lifting adenomas after previous EMR. We see quite a lot of them. So gastroenterologists, they tried to resect in piecemeal technique 1 time, 2 times, and then the lesion is very scarred and can be lifted, can't be lifted again. It's not a too large lesion, but it can be resected in this full thickness technique. Submucosal lesions are also indications. Difficult locations, probably in a diverticulum, and the diagnosis of morbus Hirschsprung is also an indication to use this tool. This is such an example of a recurrence after a piecemeal EMR of a high-grade adenoma. And what you see here is this small depressed lesion. So it's a 2C, a Paris 2C lesion after piecemeal EMR. And this is how it is. The lesion is grabbed into the cap, then the clip is deployed. The resection is done by the preloaded snare. This is the resected specimen. You see all the markings here. So the resection is complete. And you see on the right-hand side, you can see the resection site. So this is the central fat, proving that we have actually a full thickness resection. And you can see here the whole colonic wall showing this full thickness situation. This is the histology of this patient, and this histology, shows the full thickness. So this is the proper muscle layer. This is the peritoneum. This is the submucosa, the mucosa with the polypoid lesion. Here, this is the cancer with submucosal infiltration, and this was a PT1B SM1, just 500 microns infiltration of the submucosa, no lymphovascular infiltration, and it was a G1 or 2, and it was R0. And we can definitely estimate the depth of the submucosa, and because we have the whole wall. So from an oncological point of view, it's not, we don't need actually the whole wall, but from a diagnostic point of view, and here from a technical point of view, it is very important that we have this whole thickness resection. These were the first data that we published together with Luzerne. These were the 33 first. This was new, they're pretty new here in 2018. So these were 33 lesions that we did with this endoscopic full thickness resection device, with the lesions in the cecum, ascending colon, you see it here, and you see the R0 resection in the rectum, 91%, in the sigmoid colon, 100%, going down to the cecum to 60%. So we have in all, we have an R0 resection rate for about 85%. And this is from the largest series from Schmidt and Chacha, showing that the resection rate, the R0, is more or less a little bit less than 80%. Adverse event rates, bleeding, pain, peritonitis, 9%, and a small rate of emergency surgery. Usually these were acute perforations that had to be operated on these patients. The R0 resection, and that's probably the limitation of this tool, is the size of the lesion. So the size below 2 centimeters gives you a high R0 resection rate versus the lesions that are bigger, it gets very low. So the place of EFTR, I think, is in recurrences after previous EMRs, not too big lesions, scarred lesions that can't be otherwise resected endoscopically. So we have a new tool also to treat these lesions. So I am almost at the end. This summarizes again, this is for our society. It can be looked up at our homepage from the society, from the Swiss Society of Gastroenterology. And you see the one from ESGE is quite similar than this, so like this. So if we have a size more than 10 millimeters, go for advanced imaging. This is extremely important to get the right resection strategy. So the benign lesions, they can be resected in standard EMR, or if the lesion is large, in a wide field EMR technique. If we have suspicious lesions of invasive cancer, we have to go for ESD or EMR en bloc. We have to also consider staging before, if we have to make the whole staging. So in US, an MRI of the pelvis to get the staging before we have resected. This, we have to consider that. And if we have signs of deep invasion, as we heard, the JNET 3, the Paris 2C, we tattoo the lesion, we make a complete staging, and we refer the patient for surgical resection. So I hope I gave you an overview on endoscopic, what we have on endoscopic resection techniques. And thank you very much for your attention.
Thanks a lot, Remus, for that brilliant talk, showing us a lot of new techniques, which actually I would say, well, this is surgery. This is kind of surgery and because it's cutting. And we will now proceed a little bit to the discussion. But first, I will have some questions for the audience. So Maite, can you please show the questions if possible? Because we want to know if you are doing these procedures already, as Remus showed. So who of you is doing some of these techniques? You can make more choices than one. If you do all of them, you can put all of them. If you do none of them, put none of them. And if you're not doing endoscopy, also please put in none of them. So the first thing is we want to know in the audience, because there are a lot of surgeons, but nevertheless, more than half of you are doing endoscopy. So we want to know who are doing these techniques first. Okay, make your votes, please. Okay, so we see that some of them are not doing, but that maybe are those who are not doing endoscopy, and only very few are doing all the procedures, and mainly the mucosal resections are done. Okay, so let's have a second question for you. After this webinar, the question is, will you change your strategy on endoscopic resection? Meaning, for those of you who are doing only the AMR, are you thinking about the other techniques? And for those of you who are not doing endoscopy, do you think you will send patients to gastroenterology who is doing these more new techniques? So if you think you will send it, or you change your strategy, put it on yes. If you will not change your strategy, say no. And if you are not sure, if it helps a little bit, you put on not sure. So please make your votes, because then we will see what happens after a webinar like this in the audience, which is rather full. And we know that a lot of people are looking it up afterwards. So you see, you made an impact of them, Remus and Alexander. So most of them will change the strategy. Some are not sure, and only 8% are saying, well, this will not change my strategy, because maybe these are the 6% who are doing everything, and only a few said, well, I will not change. And I have a last one, because what I missed a little bit was you can put the question and answer here, and I want to ask the audience if you have any further question after this webinar you want to point out. So if you say yes, that would be great. And then please put your question in the question and answer section, because now we are going for the discussion, and we will discuss all 5 of us, of course. But now you can show, if you have some of you have some questions, put that in. We will pick them up. And now all 5 of us are here to discuss, and we are happy to take your questions. So maybe, Maite, you can show us if there are, yes, there are 20% having questions. So I want to have 20 questions in the question and answer section. That would be great. So maybe I start with the first question, and I would put the assessment. Maybe we take all the questions for the assessment first. Alexander, you brought that brilliant how you should access endoscopically. For me, the question was, do you make a differentiation between colon and rectum? Does that change anything for you, or it's just a kind of lesion?
In the assessment, it actually doesn't make a difference because it's a colorectal neoplasia. So the assessment of the lesion is always the same thing. We want to rule out that there's advanced histology, and we just want to, because also what Remo said, I think what we always have to be aware, I think the best chance to do a perfect treatment is the naive, new, untouched lesion. If the first step is the wrong one, if it's an inadequate resection, then we are having big problems for the patients in the further going. So the first shot quasi is the most important one. A little difference, of course, is what you said in the rectum or in the colon, is in the assessment, is in the planning of resection. Because what we do, if we have, for example, a lesion that is suspicious for cancer in the rectum, we do a staging in advance. So we do an MRI. But what you have to be what is very important is don't overestimate the MRI, because I showed you an example which is happening quite frequently. The MRI is often overstaging lesions. So we only do the MRI in the rectum for one reason. We want to have a lymph node staging before the resection. If there's no sign of lymph node invasion, then we go for the endoscopic resection, and then we have the perfect staging, because then we get a histopathological T staging. And then we can decide whether it was curative or not. If we don't do the staging in before, and we do a rectal cancer, then we have to do the staging afterwards. And after a large endoscopic resection, of course, we will have enlarged lymph nodes. So we will get in problems to do a right staging afterwards. So we do staging before, but that's the only thing we do different in the rectum.
Let me add, because this is what I wanted to hear, that we really have to go for an MRI before we do the resection. Otherwise, the lymph nodes, we cannot quote them if we had a resection. And the other thing is, please don't put a clip in the rectum before you do the MRI, because then you don't see what you want to see. But if you can put a clip on the colon, that would make sense to see it in the CT. So if you put a clip only in the colon, but never in the rectum, because we sometimes have clips in the rectum and then they were sent for MRI, which makes it not possible to have the lesion. A little question about endosonography in the rectum. Do you think you should do endosonography also before you do the resection?
Yes, we do it, but we do it for the same reason. So we do of course, we always do the endosonography because we do it in the same session, and we see a large lesion in the rectum. We do endosonography. We do it to see the lymph nodes, and we just do it to see if there is no T2 tumor. We can't not measure the level of submucosal invasion. So endosonography is not adequate for that. And I think perhaps one message is also, I think the MRI has advantages between T2, T3, and for the lymph nodes, the endosonography is more precise in distinguishing between T1 and T2. You will never get an MRI report that tells you it's a T1 cancer. The radiologists at minimum will tell you it's T2, even if it's just adenoma. I think that's something we always have to keep in mind. If you send a benign polyp for MRI staging, the radiologist will tell you it's T2, because that's the lowest thing he can see.
Any suspicion about the height from the dentate line of the polyp? Does it change anything for you? Because this is what we heavily discuss.
No, we can do if you mean if we do resection, if we do ESD, we also go outside the dental line. Sometimes we have to inject local anesthesia a little bit, but actually it's not a problem for endoscopic resection.
Okay, let's add for the surgeons. So I think what is quite important is that we have a proper assessment for the rectal lesion, because we only have one shot. If this is a rectal cancer and we have to do surgery after you did the resection, that's a big difference. And there is a difference between the rigid endosonography and the flexible. The lower the position is, the better the rigid is, the higher the position of the lesion, the better the flexible is. So this is what we try, if possible, have maybe both, but the closer you're to the dented line, the rigid endosonography will be much better. And we are talking later about the resection. This is just for the assessment. I want to ask Andreas and Colin, do you want to add anything or have questions for the assessment?
No. Colin, your turn. Please, Colin.
Okay. Well, yeah, Walter already asked my questions, actually. I had the same question about ultrasound. But another question is there still room for a surgical local excision? Walter, I think you said, I think you're trying to say that the lower you go, the more benefit surgical local excision has. But I'm interested in Alexander and Remus, if they honest, they think there's still room for a surgical resection without being polite to the surgeons.
I'm not polite to the surgeons either.
I think this is the resection part we should discuss later on, because there will be a lot of questions to the resection part. Okay. So maybe let's just about the assessment. Anything to add for the assessment?
No, Walter. As you know, we work together in Linz. It's the best thing you can do to work together with the gastroenterologists, to do it in one endoscopic unit. And Alexander said everything, how we do it.
Okay. Remus, do you want to add anything to the assessment before we go to the question from Colin?
No, we actually, as I understood, Alexander, we are doing the same way. We are doing the same assessments. We are using the same schemes. So we are using JNET Paris, of course. Sometimes we do chromo endoscopy, and that's probably a question. If you have a JNET 2B lesion, we know that the 2B lesion covers a wide range of histologies, starting from low-grade adenoma to high-grade to superficial invasive cancers. So do you usually use, if you have a JNET 2B, do you use add-on special chromo endoscopy, or do you treat any 2B lesion? Do you treat any JNET 2B lesion with an en bloc resection technique?
Yeah, I mean, of course, we try to do advanced chromo endoscopy, but of course, if it's a 2B lesion, I always go for en bloc resection. And I think we also perhaps, it's also a little bit going then into resection techniques, but we have to be clear that there are, I think, two resection results we can have. We can have a diagnostic resection and we can have a therapeutic resection. And I think we always should give the chance to the patient to have the minimal invasive procedure that is possible. So I'm completely with you, because you also said, for example, showed that there are also some JNET 3 lesions we still go for endoscopy. Of course, we have the risk that afterwards it will turn out that we are not in curative criteria, and we have to discuss with the patient, and we still have to recommend surgery for the patient, but you have the perfect staging for this patient. But if you have especially the lymph node, the lymph vessel invasion, or if you have tumor cell budding, then you have to go for surgery. And perhaps one comment also to the criteria, I think we also have to be aware the depth of the submucosal invasion probably is the less important criteria, because, for example, the German S3 guidelines, they also accept submucosal invasion up to 2,000 micrometers. And so there's probably a field that is open, but if there is lymph node invasion, I don't discuss with the patients to tell him it's curative. Then the risk of positive lymph node goes up to 80%. So he has to be oncologically resected. And many of the features of these criteria only get by the histopathological report. So that's the reason why we also might have diagnostic resections.
So let's come to the resection part, and let's start with the question of Colin. Is there place for surgical resection? Mainly, of course, in the rectum. What do you both think, Alexander and Remus?
Well, of course there's place, but I tell you one thing. All the surgeons in Austria that I know that are doing endoscopic resections, that are doing both procedures. So there are some surgeons that are doing transanal resections, and they are also doing ESD. They all tell me they prefer endoscopic resection because that's what they tell me. The advantage of the endoscopy is you have a much better sight of these lesions because you have the endoscope and you have a big image. And also some patients, if you put in this trocar through the anus, they do have problems for some weeks after the procedure. So even the surgeons tell me that doing both procedures is that they prefer endoscopic resection. I only can tell you from the endoscopic side. So I don't do the transanal procedures, but that's my impression. And I think there are some situations anatomically perhaps where there could be reason or when we want to do a full thickness resection, something like that. But for the other things, I think endoscopy can solve most of the problems.
Remus?
It's my opinion as well. I think endoscopy can really offer. It depends on local expertise. But I think if really we have the possibility to resect endoscopically, I think this should be the way to go, also in a functional aspect. If we have a larger full thickness resection that we want to have, there is probably room for local surgical resection. If the lesion is larger, it is scarred, we cannot make a we cannot do endoscopic resection, we cannot do full thickness resection because of the size. There is probably room for local surgical TOMIS resection, probably. But I think if endoscopy works and you have the local expertise in rectal lesions, especially also in deep rectal lesions, you ask, is the anal channel, is it a problem endoscopically? No, it is not. We did many of lesions that came out of the anal channel. And if you add some local anesthetic to the submucosal injection fluid, it's not a problem, really. So also the very deep rectum is endoscopically, I showed an example, going down to the, or even down to the, or over the anal channel. So this is endoscopically quite a good position to resect, actually.
I think we all agree that transanal surgery and endoscopy is the same minimally invasive approach, doing no scars, not harming the sphincter. Maybe it's a few days, but that more depends on the lesion than on the instrument we put in, and it's necessary to have an expertise. I think if we look on the data you showed, that during the learning curve, you come from 55 to 85% of R0 resection. And on the surgical attitude, we expect 95% of R0. And this is especially in the deep rectum, very important. It's not that important if you are in the colon, because in the colon, it's easier to do surgery later on, even if you're not sure. You can do a second shot. In the deep rectum, it's a little bit more difficult. I think the advantage is what we showed in the TAMIS webinars. You can do suturing, you have a big screen, you can handle. Of course, it's kind of single port surgery, and that's maybe the thing. It's more difficult to jump over that, but people who do that see that they are over 95% of zero resection rate, and oncology should be there first. So the deeper, I would rather go for the transanal approach, having the camera plus 3 hands if necessary, and you are able to suture if you want. You can clip, you can do any kind of deep resection you want. So I'm not sure that in these cases endoscopy is a real advantage, because this is not too difficult to do in a TAMIS way. But I'm wondering what Colin and Andreas are telling us.
Well, I was worried about the same. The local recurrence rates, I think, are higher. And if you look at the Dutch trend study, which was about EMR versus local excision, the local recurrence rate was higher after EMR, and also there were a lot of unexpected cancers. So I agree with you, specifically in the lower rectum. I think it might have a benefit to do a dissection with TAMIS, but of course it all depends on the local expertise you have in your hospital. I think if you have two really experienced, like we have here, maybe they can have the same results that we have. But I think if you don't do that many resections, you only do a couple of years, then your results will not be as good. So we in our hospital, we have to deal with a gastroenterologist. We want to maintain both techniques because we want to have experience with both techniques. So we have the lower rectum are sent to us, and we do it local excision with TAMIS, and with higher up in the rectum, the rest of the colon, the gastroenterologists do their thing, and so we can both keep our expertise. And otherwise, part of the expertise is lost. So we kind of solved it that way.
Well, Walter, I think it's a matter of the interdisciplinary approach, and as we heard from the lectures, the best preoperative staging. And if you have an excellent staging using also ultrasound and the good experience and clinical communication within this team, then you can do really a lot of transanal of the endoscopic approach by the gastroenterologist, and only a few indications stay for surgery in our clinic, at least. And there's another thing which is not the topic today, that in critical lesions, there's the third option coming up. We already have 3 patients in the treatment where we had just radiochemotherapy and no endoscopical and surgical intervention at all, and they're since more than 1 year now free of tumor recurrence. So this must be an interdisciplinary approach, but we did TAMIS, we did the TEM procedure, but it's now on a very, very low level because we have the best expertise in the endoscopic treatment. But Walter, we have, I think, 3 questions from the audience before we have to close this webinar. I think we should just give 3 questions from the audience the chance to be answered. And the first is from Reimer Hago, and it's also a topic on resection. He's asking, what is the attitude regarding the new endoscopic underwater resection technique? So Alexander or Remus, who wants to answer?
So of course, this is a topic, and underwater EMR. Underwater EMR seems to get larger pieces, so larger lesions can be resected in this underwater technique. I actually do not do underwater EMR. I don't know, Alexander, if you do it. Sometimes it's hard to get really this underwater situation. It helps you to resect the lesion without submucosal invasion and without making the lesion bigger with submucosal injection. So I don't have my own experience with it, but it is a big topic, actually. It is true, but still we are talking about EMR then, huh?
Yeah, perhaps I just want to do a comment on that, because I think that's really one of the new techniques which I'm quite frequently starting doing it more and more. And the more you do it, the more you get a fan of it. Perhaps for the ones who don't know it, what it is, underwater EMR means that we quasi float the colon with water, and we don't insufflate air or CO2 anymore. And the advantage is you have zero perforation rates. I mean, not zero but you really don't have perforations, even without injecting. So I just did one in the cecum, really large EMR just a few days ago. And the mechanism how it works is by just having water in the colon, the muscle layer will not go into your snare because the mucosa is floating into your snare, and you can just close the snare, and the muscle layer will never go into the snares because we don't have to suck the air out when we close the snare how we usually do it. We don't have to inject, and you easily can resect very fast, do a piecemeal EMR with just underwater. And the location where I'm also doing it more and more is, for example, in the duodenum, where you really can do a nice EMR with very low risk. So I think it's a new technique. It's getting more and more, and it probably will make it more easier, because important thing is by injecting under a lesion, we are always making it much bigger. And the 2 centimeter polyp, after you inject it, it's getting 4 centimeter, and you have to do a piecemeal. If you do underwater EMR, you can do en bloc resection in 30 seconds.
Okay, thank you. And there's another just guest in the session, an anonymous one who asks, if a lesion is not completely resected, do you do a later completing procedure? And just before this question, I would like to ask, is the piecemeal technique gone, or is there still an indication?
As I showed you in my talk, piecemeal resection, even in these benign lesions that we can predict a benign histology, piecemeal resection gives us a very effective technique to resect even larger lesions with a very low rate of complications. So piecemeal EMR for benign lesions, for these LSTs, granulars, homogeneous, is still a technique that is state of the art.
I think the important thing is, please don't do that in the rectum, as you know, because in the rectum, then the pathologist will not be able to tell us if this will be SM1, 2, or 3, because at piecemeal this is gone. So I think this is important. In the colon, it's not that. I agree, but in the rectum, it's really important. Don't do that.
I think that's probably the most important thing is we have to differentiate if we are doing something in the rectum or in the colon. And also from the endoscopy side, it's completely the other way around. And especially from the patient's point of view, it's a big difference. It's, in my point of view, if I have a patient with a big adenoma in the cecum, where I can do it endoscopically, but it might have a big risk, a laparoscopic surgery won't harm this patient in his life quality. But if we have a lesion in the lower rectum, we have to do the best endoscopic treatment for that patient in the first chance we have to have really a complete R0 en bloc resection, because the alternative of surgery in the lower rectum is a big difference for the life quality for the patient. So that's a big difference. So in the lower rectum, endoscopically, we will go for high risk, and we will use techniques to go for en bloc resection. If we're in the upper colon, I think the alternative of surgery is still not a big deal for the patient for his life quality.
Okay, thank you. And to come back to the question, if the resection is not completed, what about the redo procedure endoscopically?
Depends on the histology you get. So if it's a benign lesion, you make control and you can treat the recurrence, so the residual adenoma endoscopically, again, as I showed from this Australian series, with a very high percentage of success, which is for the residual or for the recurrent adenoma, you have a chance for about 85% to do a complete endoscopic resection. So a first approach, again, endoscopic approach, or if it's a high-grade adenoma that has a recurrence, you can, or that's the way we do it, we then do a full thickness resection. So then the pathologist has really the whole specimen to make the proper histologic diagnosis. So I would say if the recurrence comes, of course, a first endoscopic approach, respecting the histology, what you do next as an endoscopic procedure.
Perhaps I just want to do one more comment for the recurrence. I think you also have to always to keep in mind, we almost told it, if you do a piecemeal resection, we have to do a follow-up in 3 up to 6 months. We usually do it in 6 months. Don't do it too early. If you're doing it, you have to give the recurrent or the residual adenoma the time that you can see it. So don't do it after 6 weeks, for example. So you have to do it after 3 to 6 months to see the recurrent adenoma. And then you should not make the mistake after, if the second look at 6 months is okay, to lose the patient in follow-up. So after we're doing a piecemeal EMR, we do the first check after 6 months. And then after 1 year, we also can do an extra colonoscopy, or at least after 3 years, but not after 7 years, because then you will have perhaps a cancer and you lost the patient in follow-up. So if it's piecemeal EMR, don't lose the patient and keep him in follow-up and not stop the follow-up after 6 months.
Okay, thank you.
Thank you, Andreas, for presenting us the questions. It's 6:30, so I think we're coming to the end of this webinar and this session. So I want to close this session, but not before I thank Remus and Alexander for their great presentations. It's good to have colleagues in different specialties who are this experienced and share their experience with us. And I think it will really add to this colorectal webinar series. So thank you again. Also, thanks to Walter and Andreas for sharing this webinar series and doing this together. I think it was really great. And this was the last webinar, but maybe we can convince Maite to do something extra in the future. I think Walter will have some ideas. So we might come back. And at the end, I want to thank, of course, Maite, who was always the backbone of this colorectal webinar series, and who's always chasing us and making sure that everybody is here and everything was arranged. So Maite, thank you very much. Really looking forward to the final web search web page, and also for the participants who are still here, please have a look on web search in the coming weeks and have a look at the Colorectal Basecamp webinar series. And I think it will, the promo is already there and it already looks great. So everybody, thanks again, and I hereby end this session.